Hi, everyone. Thank you for joining this session titled Scale Up of Community Vital Signs Dashboards. My name is Toby Merck, and I'm a public health analyst on the maternal mortality prevention team here at CDC. And I'm pleased to introduce our speaker for this session, Michael Kramer, Dr. Michael Kramer. Dr. Kramer is an associate professor of epidemiology at the Rollins School of Public Health at Emory University, where he teaches maternal and child health epidemiology and methods in social epidemiology. His research interests are largely centered at the intersection of perinatal and early childhood outcomes, social determinants of health and spatial analysis, including work on residential, economic, and racial segregation and preterm birth, and neighborhood deprivation and early academic readiness. Before I turn it over to Michael, just wanted to share a quick reminder for our audience today to please ask your questions in the chat throughout the presentation. We'll be monitoring the chat and we'll reserve some time at the end to pose your questions to Michael. Michael, over to you.
Great. Thank you so much, Toby, and thanks for everyone for joining. It's a pleasure to be here with you. So as Toby said, I'm going to talk about the latest updates for what we're now calling the ERASE-MM Community Vital Signs Project. Now, if you've come to a MUM meeting in the last few years, you may have heard me speak about this project as it's evolved over time. It was at one point called the Health Equity Toolkit, and then just Community Vital Signs, and now we're calling it ERASE-MM Community Vital Signs Project. And the most exciting thing is that in years past, we've been telling you about this set of tools, but we haven't actually had something to share with you. And so in just a couple of weeks, we're actually going to have a website where all of the states who are participating in ERASE-MM can go to the website and can actually access a range of resources and materials and produce your customized community vital signs dashboards for your reviews. So I'm going to talk more about that in just a moment, but I just wanted to say that up front, that we're the direction we're headed is just in a couple of weeks, everybody being able to gain access to these resources. All right. So to begin, I want to just give a little bit of background, recognizing that not all of you maybe have heard me share updates about this project along the way, and so it may be unfamiliar to you. So the motivation for the Community Vital Signs Project really comes from a recognition that the occurrence, the risk of maternal mortality, of maternal death, is not just a constant in human populations, but that it varies across social strata. So we know that it varies by race, by class, by geography. And we see that it varies within race by geography and between race as well. And so that recognition got us thinking about the importance of both social characteristics like race and class, but also the role of place in understanding something about risk. So as any of you all know who are involved with MMRCs and are using the MURIA system, the MURIA system structures your goal as a committee around a set of questions. Things like, was the death pregnancy related? What was the underlying cause of death? Was the death preventable? Two questions that really frame the work that we've done in the ERASE-MM Community Vital Signs Project are these fourth and fifth questions. What were the factors contributing to this death? And these factors can be conceived of at different levels. And what are the recommendations to address those contributing factors? So a number of years ago, as a few states began to pilot the use of the MURIA database when it was newer, CDC presented a report from the first 9 states that shared some of the data from their MURIA reviews. And one of the findings from that 9-state report was this figure here, which is a summary of how many contributing factors there were at these different levels. For example, at the patient family level, at the provider level, facility, systems of care, and community. And not surprisingly, there were a lot of factors at the patient and family level, a lot at the provider level, some at the facility level, a number at the systems of care, but really not very many at the community level. Now, what makes me say not very many? So as Toby said, I do a lot of work in the social determinants of maternal and perinatal health. And there's, outside of maternal mortality, a really large and pretty robust evidence base that there are important community and social determinants of pregnancy outcomes, and that some of these are really causal. And given that evidence base, we might have anticipated that there would be an important role for community also in maternal mortality, but that didn't show up here. So as a result, we began thinking a little bit about what might be barriers to state and local territorial MMRCs having conversations about community factors. Are there factors that are going on that aren't being recognized? And so we identified three sort of broad categories of barriers. One kind of barrier, apologies. One kind of barrier might be around the knowledge or beliefs of the members of the committee. There might be a belief that social or community factors are not main drivers, or perhaps there may be a lack of knowledge about this body of evidence, this scientific evidence for social determinants of health. Another potential barrier is the availability of data to support these claims. It may be that many members on the committee do recognize the importance of social determinants of health, but they simply don't have information available in the case review, in the narrative, that would support naming a particular contributing factor from the community or from the social environment. So the missing data. And then there's also this concern about modifiability, or what are the recommendations we would make. So it may feel challenging, particularly if a committee is very comfortable making recommendations about clinical care. It may feel challenging to suddenly shift gears and make recommendations, for example, about social policy or about neighborhood policy or programs. So we identified these things as potential barriers that were possibly contributing to why we saw a small number in 2018 of contributing factors at the community level. So in terms of what the Erase Community Vital Signs project is now, like what are the tools or the resources it encompasses? I sort of think of it in these buckets of things. And what I'm going to do is just at a high level, walk through each of these things, each of these components that are resources that are available as part of the Community Vital Signs project. So the first sort of bucket is filling that first potential barrier or gap, which is about a knowledge gap or an understanding of sort of what does it mean to understand the causes of inequities in maternal mortality. So this involved the development of an evidence-based conceptual model that was built on evidence from other maternal and perinatal evidence bases. And one outcome of that was a paper that came out in 2019, I guess, in AJOG, that summarized the role of MMRCs in thinking about how to change the conversation to incorporate not only clinical factors, but also factors along the life course. And in particular, the things that the Community Vital Signs really focuses on are attributes of the community context and the fundamental social determinants in the community in which the decedent lived prior to the tragic events that resulted in her death. So that was one piece, and we've also developed a number of training tools that I'm going to show you about in just a moment that provide your committee with some of that background, that provides a bridge to be able to have those conversations. Now, the second piece was about providing data. How do we actually begin to share with a committee what might be important aspects of the community or the social environment that affected this individual's navigation through the preconceptional period, through pregnancy, possibly through labor and delivery into the postpartum period? What are the things, what are the environments that she was navigating during that time period? And the way we're providing this data is through what we're calling the Community Vital Signs dashboard. And so it includes a couple things: the identification of evidence-based sociospatial data indicators, and then the delivery of those indicators to you in a particular data visualization that is specific to each case, specific to each decedent, and allows you to incorporate that into the review. So just again, briefly at a high level, the indicators, the measures that we're looking for are selected based on a number of criteria that they were grounded in our conceptual framework and theory and empirical evidence about social determinants of maternal health, but also that they were measurable at geographic units that approximate the community in which each individual lived, that they're measurable across all states so that we could scale this up to be available for any state that wanted it, and that they're measurable over time so that we can make customized approximations of this environment, not just in one period of time, but over time. And so here's just some examples of some of the indicators. We're interested in characterizing sort of the supply and demand of the general health service environment. Things like how many providers are there, but also how much of the population is uninsured or has poor or fair health. Also, the supply and demand of the reproductive health environment, the behavioral health environment. Really importantly is the transportation environment, which links individuals to be able to access the care. And then a number of indicators that are getting at different aspects of the socioeconomic environment. Some things are things like neighborhood deprivation or social capital, but also measures that might be approximations of structural racism, including the degree of racial or economic segregation. Now, these measures, again, were chosen because they can be identified at a granular scale over time and space. And so what do I mean by that? What I mean is we can produce unique measures of each of those attributes across geographic space, and specifically the indicators are either measured at the census tract level, which we sort of use as an approximation of neighborhood. It's not a perfect measure of neighborhood, but an approximation. Or many measures are available at the county scale. So two different geographies depending on the measure. And then again, importantly, the measures are time specific, so that most of them are updated annually. Some are updated every few years. So if your committee is reviewing cases from 2016, 2017, we can align the measures with 2016 or 17. But also as we're moving forward, as you're eventually reviewing cases from 2021, we would have indicators that are appropriate for 2021. Now, in this particular talk, in past talks, I had spent more time sort of unpacking how to interpret the dashboard. I'm not going to do that today, but this is just at a high level, this is what the dashboard looks like. And what I will say is there's one unique version of this for each individual case based on where she lived. So you could be reviewing 10 cases on a particular day, and you would have 10 different versions of the dashboard appended potentially to each of the cases, so that you would know this is the environment for this particular case. If we zoom in just a little bit, and again, I'm not going to go into the nitty-gritty of interpretation, although we definitely provide a lot of support on the website for your own self-training and for helping committee members do this. But at a high level, what you can imagine is that for the indicators, for each of the indicators, we represent the decedent's value with these dots. And so if you look at these dots here, the dots fall within a colored zone on this rectangular spectrum here. And so if you see, for example, particular dots that fall in the red zone, just in qualitative terms, what it represents is that her particular neighborhood was higher risk than most other neighborhoods in your state or in the country at large. But basically, it gives you this relative comparison, like, is this an unusually risky environment for this particular indicator? And in that way, it begins to help you gauge, like, is this something unusual happening, or is this a kind of typical neighborhood, which would be more the middle area, or is it a better than average neighborhood, which would be, for example, the green area? Now, a challenge that we've had in interpretation, and that many of you all have expressed through question and answers as we've navigated this over the last few years, is there's inevitably a gap between the ideal data that we would like to have and the real data that we actually have. The ideal data is that we would really like to know what were the true social, economic, policy, and community level opportunities and constraints that shaped each person's health prior to their death. That's what we'd really like to know. What the dashboard helps you do is something that's close to that. It helps us, it provides data indicators of the social, economic, policy, and community level factors, but it's specifically in the neighborhood or the county in which each person lived. The distinction I'm drawing there is we don't know for certain, for example, if there are a small number of healthcare providers in this person's county. That doesn't tell us for certain that that person didn't have access to care. What it tells us is that that person lived in an environment where there's less than the optimal amount of care available. So when I think about how does the Community Vital Signs dashboard connect with all of the other resources that are already part of the MMRC review process, in addition to all the new resources that you're learning about this week or over these 2 days, I think of it as layers of data, different data streams. And what we would like to do is we would like to integrate these data streams in a way that tells a more holistic story of how this individual went through her life and what exactly happened in these final stages. So if we think about some of those particular layers, we've got a lot of medical clinical information, for example, information from the delivery hospitalization or information from the postpartum course. But we also layer that with perhaps outpatient information, for example, prenatal care visits and summaries, emergency department visits, behavioral health visits, social services. And then the community vital signs dashboard falls into this broader layer, this background layer that provides social context. Another important piece of social context that some states are beginning to investigate now is carrying out key informant interviews. So actually interviewing survivors in the family who knew the decedent to get more social context. So I really think of the Community Vital Signs dashboard as contributing to these layers of information that together provide a more holistic story. Now, a few people have asked, what is the evidence for these particular indicators? How do we know that they are in fact predictive or correlated or even possibly causally related to maternal death? Well, as I said, there's a pretty robust literature for other maternal and child health outcomes. Because maternal death is relatively rare, there isn't as large a literature for maternal mortality, but it is rapidly growing. So I just want to call out one paper by colleagues that just came out in the Green Journal just a month or two ago that used the same indicators that are on the dashboard combined with the pregnancy mortality surveillance system, the PMSS, which is the National Surveillance System for Pregnancy-Related Mortality, and evaluated the relationship between county-level sociospecial indicators and pregnancy-related mortality overall and separately by race ethnicity. There's a lot in the paper. The paper is available. I'm happy to share it, and I think it's actually available maybe in other places on the MUM website, but just a few high-level findings. There were some county-level sociospatial indicators that were protective. When you had more of them, you had lower pregnancy-related mortality rates. And these included, if you have more mental health care providers per capita, the maternal mortality rates were lower. If you have higher median household income or higher prevalence of college graduates, they were also lower. But on the flip side, there were selected risk factors. So in other words, when these factors were higher, there was significant increases in the pregnancy-related mortality ratio. So for example, as the number of uninsured females increases, or as the neighborhood deprivation, or the prevalence of housing instability, or violent crime rates increase, we also see significant and meaningful increases in pregnancy-related mortality. This isn't the end of understanding kind of the evidence base for these indicators, but it's a first step in that process, and it's something that we're going to continue to work on. Okay, so that was a little bit about the middle barrier, which was about providing data. But a final piece I want to talk about, and I've actually talked less about this in past years, so I'm excited to share a couple other resources here, is this piece about, well, so what? What can we do as an MMRC? How do we write recommendations if the problem was something that doesn't have anything to do with the healthcare system? If it's about housing instability, what do we do about that? So what we want is this link to action, this opportunity for you to begin to make recommendations that are tied to the community and social determinants of health. The first thing I'd say, much more important than any resource I can provide, is that the diversity of your committee is a really important tool to making impactful recommendations. And I mean diversity of your committee in a couple different ways. I mean the diversity of lived experience among committee members. So lived experience, social position, people's worldview and vantage point, all of those things shape how they see the world. It shapes the ways they see things as modifiable or fixable or not. And so somebody may look at a particular case in one way and say, that doesn't have to be that way. We could change something. Whereas somebody else may throw up their arms and say, I don't know what to do about this. So diversity in terms of the lived experience in the committee matters. But also the diversity of professional disciplines in the committee matters. Now, this is, of course, something that CDC has been encouraging for some time, but making sure that your committee not only has diverse disciplinary representation, but that they also feel empowered to participate in the conversation. So, for example, we certainly need clinical input, but also we need people who understand Medicaid in your state, social work, behavioral health, substance use, people who are violence interrupters, people who are public health experts. Each of those different disciplinary vantage points may have a different sense of what are the levers for action. What are the things, the recommendations that could make a difference? So more than any resource I could give, I would say it's who's in the room who can see this problem from different vantage points. But we do want to provide some resources to begin to help as a jumping off point for what are evidence-based recommendations that we can provide. So we've got something called the recommendation reference tools, and actually we have two of them. One is a systematic health literature, maternal health literature review that our team conducted and that we synthesized, and I'm going to show some screenshots of it in just a moment, that basically gives, here are things from the peer-reviewed and from the gray literature that have some amount of evidence for programs or policies that are not clinical that may make an impact in terms of maternal health. And the second tool I'm going to share is actually something that I'm just extracting from the Robert Wood Johnson Foundation. So you may be familiar with the Robert Wood Johnson Foundation's County Health Rankings Roadmap. They've been working on many aspects of social determinants of health across the life course for some time. And one of the things they've done is they've curated a nice collection of specific evidence-based policy recommendations. And I've extracted some of them that are particularly relevant to reproductive health. So briefly, this is what the maternal health literature review tool looks like. So it's basically a document that has hyperlinked topics, and you can click on one of these and it'll take you to that particular section and give a narrative summary of the evidence that was identified. And the Robert Wood Johnson Foundation's recommendations are a wide range of things. The table that we provide has 85 different evidence-based community policies or programs. And this is just an example of some of the domains that they cover. For example, there's 16 different policies or programs that are specific to access to care. There's 11 about family and social support. There's 15 about housing and transit. So there's a number of resources that are available there. So the way that I envision that recommendation reference tool kind of coming into play is that it's a conversation starter. It's a place to begin in terms of brainstorming what are recommendations that tie to the particular contributing factors we've identified, especially when the contributing factors are at the community level or perhaps at the system of care level. So this is a slide that I blatantly lifted from some prior CDC presentations. This is just a reminder that sort of best practices for writing actionable recommendations are that you should have a who, should, do what, and when. And again, I'm particularly interested in those pieces that apply to the facility system and community level. So I'm just going to give a very brief example of how a particular case and some contributing factors might lead to some particular recommendations and how you might use these resources. So the example, imagine that there's a case you're reviewing. Teresa was a 33-year-old residing in an urban area. Medical records documented many missed prenatal visits despite multiple cardiovascular risk factors. We know that she was evicted from her home in the postpartum period. She died from a PE in the postpartum period. Now, when we look at her community vital signs dashboard, they demonstrate that Teresa's community had worse than average values on the percentage of people covered by insurance, on the teen birth rate, the number of mental health care providers, the amount of housing stress and instability, the amount of residential turnover, the neighborhood deprivation index, and violent crime. Now, together, this represents a context or an environment that suggests there's not a lot of collective social support. It doesn't tell me for sure whether she has social support in her family, but it looks like an environment where there's a lot of stressors and there may not be the connections that help you make the leap to the resources that would make your care optimal. So this is the clues that we get from that layer of information. And then there was also, of course, information from the rest of the review. So let's imagine that we take those bits of information and we go to these recommendation resource tools. If we look at the maternal health literature review, you might click on evidence about the home environment, or about the risk monitoring and prevention, or about transportation and location. And there's a number of things that might be relevant as you review those areas. For example, there's some evidence that multidisciplinary home visiting for high-risk moms postpartum is acceptable and produces optimal outcomes, or evidence that community health worker home visiting can really help with particular social supports. And with respect to navigating care, a pilot of a Medicaid managed care intervention for high-risk postpartum moms, including social work and financial support for transportation. So providing not just that clinical checkup, but also making sure that there's those additional needs met. If we were to look at the Robert Wood Johnson Foundation tool, it's actually an Excel sheet. And what you do is you use that little filter in an Excel sheet. And so if you choose the filter, you can check the box for what category you want. And if I chose, for example, housing and transit, these are the recommendations that come up. And just a couple recommendations that I pulled out that seemed relevant to this case. There's actually evidence of communities establishing legal aid and debt counseling for those with threatened eviction to reduce the risk for eviction, or using housing mediation services to facilitate conflicts between landlords and tenants. And then, of course, access to care, thinking about something like Healthy Babies for Healthy Communities as a broad spectrum case management. So perhaps your committee looked at those tools and had some conversation and came up with some recommendations. Here's just 3 possible recommendations. Maybe discharge planners should screen for barriers to care in the postpartum period, including specifically transportation and housing, and when identified, link to social work case management prior to discharge. Or a recommendation might be that Title V or Department of Public Health should enhance home visiting programs specifically for high-risk persons to include evaluation and referral for childcare, transportation, and housing instability in the postpartum period. Or that Medicaid should implement a medical transportation program for pregnant and postpartum patients. And just to point out, each of these does have a who should do this, has a do what should they do, and has a when should that happen. So this is a relatively simple and fast example, but the message that I want to convey is that if your committee is engaged in thinking about social determinants of health and you begin to identify these community level factors, don't feel that there's nothing that can be done. There are many unique and creative ways that communities have tried to address these things, and we can try to contribute to that creative recommendation. Okay, so now I want to talk a little bit more specifically about the tools themselves and how you might begin to use the community vital signs tools in your MMRC. So I kind of touched on this before, but I just want to point out kind of where we are in the history of this. So we started working on this in about 2018. We did a little mini pilot with Dr. Collier in Mississippi of the first version of the dashboard. And then over the last couple of years, we've done a year-long pilot with the MMRCs in North Carolina and Illinois, and used information from that to refine both the tool and also the resources we're providing. And so what we're really excited is that now in 2022, in just 2 or 3 weeks, we're going to have this website that will go live that you will be able to access a lot of the resources. And it is also our intention that moving forward, we're going to continue to build the evidence base, including adjusting the indicators on the dashboard as evidence suggests, and also continue to provide technical assistance to states as they begin to incorporate these tools. So this is the website that will eventually be live. If you go to this now, there's nothing there, but this is where you will go, erasemmcdsproject.org. We anticipate that the soft launch will be late May 2022, so just a couple weeks or so. A few things I want to say just about how to go about starting. We really encourage committees to take this on very intentionally, and that may mean starting with a self-assessment of your readiness to engage with thinking about community-level social determinants of health. So assessing, for example, your MMRC organizational culture, continuing to think about the diversity of the MMRC membership, taking advantage of resources for training and technical assistance. I'm going to show you some of those in a moment. and creating a supportive MMRC leadership structure. We've developed not only sort of training tools, which is going to ultimately take the form of narrated PowerPoint videos on YouTube that you could send to your committee to do, that will be anywhere from 6 to 15 minutes in length, so trying to keep them short. So we've got a number of those, but we also have things that we're calling work aids, so templates or cheat sheets or references that you can download, and maybe abstractors might like to use them, or perhaps the committee members want to use them. So this is just a list of the kinds of resources that are on the website. And again, as you're thinking about preparing the planning, I really think the planning for implementation is going to be important. So preparing and training your leadership, your abstractors and members, thinking a little bit about the process. We initially had in mind that the community vital signs dashboards, those colorful sheets, would actually be part of every case narrative. But what we learned in working with some states is that some states felt like their committees were overwhelmed with how much information they have, and they wanted instead for the abstractors to put the contents of the dashboard in a narrative form on the narrative itself. So what process do you want to do? Do you want your dashboards appended to the cases? Do you want them summarized in text? Or do you want a combination? I believe that the combination gives the most flexibility, but I also recognize that each committee needs to decide what works for itself. I would also anticipate, as there is with any new tool, or even if your MMRC is relatively recently established, anticipate growing pains. This is a new tool. It's going to take some time. It's going to take some practice. I would encourage you to solicit feedback from your abstractors and committee members after the first use, but also keep using it for several times and then resolicit information after people have become a little more familiar with it. And certainly engage with CDC and our team as you have questions for technical assistance, et cetera. In terms of how, if you are, for example, the abstractor and you want to begin to access the dashboards, how is that going to work? Ultimately, there will be 3 sort of ways to get them. Right now, there's 2 of them that will be live once the website goes. You could either get one dashboard at a time, so you would go to the website and retrieve a single dashboard, or what I anticipate will be more frequently useful is you will have, for example, the set of 10 cases that you're going to discuss in June, and you do a bulk download. So essentially, you're going to put the information in for all 10 cases, and what will be returned to you is a zip folder that has the dashboards for all 10 cases. What's really exciting and will probably be forthcoming in the fall of 2022, we're working with the tech development team on Maria to actually make it possible for you to click a button in the Maria system and it to automatically attach the dashboard in that way. So that's forthcoming. And in terms of what do you need, what information do you need to get the dashboard? You need 3 things. You need a unique ID, and probably that could be the Maria ID, the system generated ID, but some states generate their own IDs. What's important about that is that ID will be printed at the top of each dashboard. So that's how you keep track of which dashboard it goes with which case. You need the year of death, and then you need the latitude and longitude or the street address. So for those of you who actually are working day to day in Maria, you know that once you put in information from the death certificate and birth certificate, you can push a button and it will geocode for you. One of the things it does is gives you the latitude and longitude. This is what the website looks like at this moment. We're still tweaking some things, but when you land on it, it's just a very simple, straightforward website. There's going to be some top-level information here, but really what you're going to do is either click on this button to receive an individual dashboard, or on this one to do a bulk download. And then under this documentation tab is where all of the training, technical assistance resources are. Again, this is all of the different resources that are available. So all of the PowerPoints, for example, already exist. We're waiting for them to get cleared through CDC, and once they're cleared, then we're going to create these narrated YouTube videos that will be embedded in the website. So you could, for example, just have your committee go watch, the first and the third video in preparation for their first use, for example. So these resources, again, they're organized in a particular sequence that we think makes sense. They start with helping your committee think about, are you ready? They help you have an overview of the Community Vital Signs project broadly, and they help you specifically in how to interpret the Community Vital Signs dashboards. and then how to use the recommendation references. And then we have some specific things that are targeted at abstractors. For example, if the abstractor is going to be asked to translate the dashboard into narrative, how might they do that? And also information for analysts who might be interested in using these indicators for end-of-year reports, where you might want to do aggregate reporting. And just briefly, this is what it looks like. You choose the year, you put in the ID. In this case, I just entered an address, and you can click on this button and it will generate the PDF. Or in the bulk or the multi, you just enter a list of the lat longs and the IDs. And when you click generate data for locations, you'll get this zip file. There's actually already a script or a function written into the Maria system to create a file that has this information. So for the abstractors, you would just run that script and then copy and paste it into here. And again, EPIs and analysts, if you're interested in accessing the raw data, so in other words, if you don't want like one dashboard at a time, but you would like to know what are the distribution of these indicators for my whole state so that I can use it in some sort of aggregate reporting, we've also got an ability to download all of the county or all the census tract indicators we're using for your particular state in a particular year. Okay, so in conclusion, it's my opinion that incorporating the vital signs dashboard is going to require more than just stapling that colorful piece of paper onto the back. I think it's going to require careful thought, readiness assessment, planning, training, and support. But I'm hopeful that it's also going to be a really valuable additional layer of information to add, and that it's going to complement existing data streams, that it adds something that you can't get from those other streams. It doesn't stand alone. It needs to be used in partnership or in coordination with those other data streams. The recommendation reference resources is a supplement to having a diverse team and their insight into what are the things that can be done in those communities. But we hope that it is also, as I said, a jumping off point for conversations about innovative community-based interventions. And then, as I said, this website will soft launch by the end of the month, and somehow or other, we'll figure out how to make sure everybody who attended MUM gets access to that and knows when it's available. So I think I don't know if I've talked too long. I think I have time for questions, though. Thank you all for being with me.
Thanks so much, Michael. And just a reminder to folks, I don't think anyone's having any issues with the question box because we have had a number come in, but just a reminder to please submit your questions in the question box on your screen, and we will do our best to get to all of them. So Michael, a number of questions have come in. First one, actually, I will be able to handle because it's just a question if the slides will be shared. And I wanted to note that the sessions are being recorded, and those recordings will be available, but we're not necessarily sharing the slides. So Michael, one of the questions that came in when you were talking about when you showed the snapshot of the Community Vital Signs dashboard was just what are the data sources for these geographic measures? Could you provide some more background there?
Absolutely. So the first thing I'll say is we have a whole 10-minute training video on how the indicators were chosen, what are the data sources, and how do we get them. So we're definitely interested in being transparent about where these come from. So they come from a number of sources. Actually, the Robert Wood Johnson Foundation County Health Rankings is where many of them come from. Robert Wood Johnson actually partnered with CDC, National Center for Health Statistics, and some other organizations, and was able to produce a number of county level indicators that were not otherwise publicly available. So that's a source for many of them. We also use the HRSA Area Health Resource File. That's where we get all of the information about, for example, the number of providers. So how many general practice docs, how many OBGYNs, how many certified nurse midwives, how many mental health care providers per capita. So the Area Health Resource File. A lot of the social and economic and demographic factors come from the American Community Survey, which is basically the census data. That includes information on who's insured and who's not insured. We do some additional processing. The segregation measures, for example, are derived from census data, but then we actually produce those segregation measures. So they come from several different sources, but we've chosen them. Sometimes there are individual years or individual states where there's a really neat variable, but it's not available over time or it's not available for other states. And for this particular use, we decided that we really wanted something that could be used relatively universally. That doesn't mean that there aren't sometimes additional resources you might have in your own state for neat data sources. So, but they come from many identifiable sources. You could actually go download the data yourself if you wanted. What we've done is just kind of harangue it into shape so that you don't have to do that.
Thanks for that. And another question, would there ever be an instance where a dashboard would not be available for a case, for example, related to someone living in a rural area or the person not living at an address for a particular amount of time?
That's a great question. So if there is, the dashboard is generated based on the address that's in the information in Maria. So if someone were homeless, if they really don't have an address, or for some reason the address was not captured on a birth certificate or a death certificate, if there was no address, then we would not be able to provide a dashboard because we do need the address. If someone's in a rural area, that's not a problem. We do have complete coverage in rural and urban areas, so that wouldn't ever be a problem. There are also a few census tracts where theoretically there are no residents, but occasionally somebody puts an address that's there. So I live in Atlanta, and one of them is the Hartsfield-Jackson Airport. So there's theoretically no residents, but occasionally somebody gets geocoded to be living at the airport. And that would be kind of a fluke where we might not have a dashboard because theoretically there's nobody who lives there. But for 99.9% of the time, if there's an address, there will be a dashboard. If someone doesn't have an address, that makes it more difficult.
Thanks, Michael. And maybe a slight follow-up to that is just a question that came in around housing instability and how the address on the death certificate might not actually reflect the residence where that person lived. And if you had any thoughts about that, you know, when a state is selecting the primary address, if they do want to geocode, kind of where they turn to first. And yeah, speaking to the data quality piece, pulling from a death certificate if it might not accurately reflect.
That's an excellent question. And that's going to take a little bit of judgment on the part of the abstractors and or the committee in thinking about what information they have. So there's a couple of issues there. One issue is about residential mobility. So what if someone lived in one place at one point and then a different place at a different point? If you know both those places, you theoretically could produce a dashboard for each of them, right? So any place you can, any address you have, we could have a unique dashboard for that location. So if it felt like that was an important part of what was happening here, that maybe this person lived in one kind of place, you know, during pregnancy, in a really different kind of place after pregnancy, then that would be possible to capture. So the residential mobility thing is getting at how do people move through time. We know that lots of people move during pregnancy, that pregnancy is a big life event where people often move to a different house. And so it's not unexpected. One thing that we also know is that most people don't move to a dramatically different kind of place than they lived previously. It's not impossible, but most people's economic circumstances don't change dramatically. And so while they might have lived in one place, you know, at one point in time and a different place later, many of the indicators or the kinds of attributes about the variable may be similar across them, but that could be evaluated. In terms of which you might prefer, so I think that what has been happening in the pilot states is they primarily used the residence at the time of death. I think that as you begin, it probably makes sense to start simple and choose one thing, probably the residence at the time of death as being the thing that's most proximate. I think the idea of adding in, for example, multiple dashboards for where did this individual live during pregnancy, at the time of birth, and at the time of death, if those were three different places, I would maybe hold off on doing that until everybody feels comfortable kind of working with the data and thinking about those issues. It's not an insignificant concern. The fact is, as I said, there's the ideal data. What was the actual environment this person experienced? And there's the realized data. What are the indicators in the place at which this person resided at a particular point in time? And we would like to be as close as possible, but the fact is we would have to know all of the places they traveled through their life to know all of that.
Thanks, Michael. Lots of questions coming in. Another one, how are the indicators going to be updated, from the data source that informs the dashboards?
Excellent. So we've been spending a lot of time really thinking about how to optimize the sustainability, the updating of the data so that it can carry on moving forward. So one of the things that's meant is we've automated the way that we, for example, pull the data from those three main sources I told you about: the American Community Survey, which is like the census, the Robert Wood Johnson Foundation, and the Area Health Resource File. So we have data pipelines that essentially once a year we can push a button and the pipeline will sort of go into action. It'll retrieve the raw data, create the clean data sets, and push it out to the website. That being said, I also recognize that things are going to change and we're going to have to adapt as we go along. Some variables may get dropped or some new variables may get added. Or really importantly, as our evidence base grows, we may decide that certain variables are simply not as useful as we thought they were, but other variables are. So there will be changes over time, but we've actually spent a fair bit of energy and time making an information technology environment that allows us to relatively automatically keep these updated from year to year.
Actually, an interesting process question coming in as well. Would be curious on your thoughts whether states should document somewhere in Maria if they use the dashboard in case review.
Wow, that is a great question. And so I'll talk more to the CDC team after this. I think that's a great suggestion because one of the things in terms of just understanding how and whether the Community Vital Signs dashboard is in fact having an impact or is it even being useful, one of the things that would be helpful to determine that, to discern that, is knowing when it was used. I do not believe there is a way to do that right now. And I doubt it would be too hard to make a way. So that's a great suggestion, and we'll follow up on that.
Thanks, Michael. Can you talk about some of the value statements or some of the ways that the indicators are phrased on the dashboards, describing communities as worse than average or poor, for example, on teen pregnancy rate, and whether those labels can contribute in some way to bias, and whether these tools can help inform decisions about structural racism?
I think that's an excellent observation and comment. And also, it's not new, but I would also, I'm very open to that criticism that the language it could be problematic. So I appreciate that. So there's a couple things. So one is, I think the language that we use about thinking about health equity does tend to get framed in a deprivation lens, in the aggregate, the absence of things, or the poorness of resources, as opposed to a recognition of communities' resilience in the face of challenges and so forth. So I think there is an important concern about the language that we use. I think one thing that this is going to take is all of us collectively being clear that most of these indicators are in fact quantifying either an aspect of or a consequence of structural inequalities, sometimes structural racism, sometimes structural classism, but they're consequences. The reason communities have more or less resources is largely because of structural, political, programmatic decisions that affect the allocation of resources. So one thing it may be necessary to do is to check ourselves and to be cautious about when we talk about social, worse than average or better than average, that we're clarifying that this is the contextual environment that was created over time, over history, in which people live, rather than some attribute of the people who live there. So I think that's what I would say, is that it's partly about language, and it's also partly about interpretation. That if we can frame and interpret these as measures of structures and not as measures of persons, that helps. But I'm also certainly open to improved ways that we can use language to make that clearer. So I feel like that's part of an answer. I feel like that's an incomplete answer to that good question.
Thanks, Michael. Follow-up question about the indicators and the dashboards themselves. How have the individual factors been grouped into the 8 dashboard items?
Yeah, so there is some amount of evidence and theory informing that, and there's also inevitably some amount of subjectivity. And what I mean by that is some indicators could be considered in more than one area. So, measures that are called social support or versus fundamental social determinants of health versus transportation might all be about structural factors. So our aim was to group them together in ways that aligned with how people have operationalized them in research, and also how some programs have tried to address them. But I certainly acknowledge that there's no clean-cut division between many of these indicators, that many of these indicators co-occur in places because they have sort of common determinants themselves.
Thanks, Michael. And there's a great question that I think will allow you to talk a little bit more about the portal and about the data available in the portal. And that's, will there be a way to look at the distribution of maternal mortality cases as a group and the prevalence of the community indicators associated with low, medium, or high counts of maternal deaths over a given time for a particular jurisdiction? So kind of a summary of community risk factors for specific jurisdictions, maternal mortality review cases, maternal mortality cases, excuse me, as a group.
Yeah, wonderful question. So one of the options in the website, in the portal, will be for an analyst who is interested not just in a single dashboard or a dashboard for each case, but who's interested in this idea of how do these community vital signs vary across my state. There's the option to download just as an Excel or a CSV file all of the indicators that for all of the regions within your state for a particular year. So by that I mean all counties and all census tracts, whether there was a death there or not. And you could then download them as the analyst, and you could decide, how do you want to carry out, for example, an annual or a multi-year report of the relationship between some of these variables and the occurrence of pregnancy-related deaths. So I think that's an excellent example. You might, for example, talk about in tertiles or quartiles of neighborhood, how many deaths occurred in each tertile or quartile of neighborhood on a certain indicator, or how many deaths occurred in the quote unquote highest risk neighborhoods versus the lowest risk neighborhoods, that sort of thing. So that will be possible. Now, of course, the portal itself won't ever, it's not linked directly to Maria, so it doesn't have your state's, your jurisdiction's maternal death data. So the connection would be done by the jurisdiction analyst. But we definitely are interested in making the data available to an analyst who's interested in doing some kind of aggregate summarization. You'll obviously be concerned about or be cautious about privacy concerns in small numbers. But I do think that, for example, talking about categorizing all the counties or all the census tracts into tertiles may be a way to begin to describe some of these distributions in your own place, in your own jurisdiction.
What about local data, local metrics that are not necessarily applicable nationally or included in this data set? What are your thoughts on ability or capacity to do that here?
Yeah, great question. This has come up several times over the years. Um, I think that I think it can be very exciting to think about local data sources you have that may feel particularly pertinent to your jurisdiction or your region, or that are just available in your jurisdiction or region but aren't available elsewhere. We do not currently have plans to incorporate customized data into the dashboards. We did think about it. It's technically challenging to think about how new data might come in for some places and not other places, and then also how we would represent it on the dashboard. But that doesn't mean that individual states and territories and jurisdictions can't use the same logic that we're using, which is to say, if you know where an individual lived, then you have geographic information. And if you have another data source that captures attributes of that place, you can connect them together. I would be happy to have more conversations with anybody who's interested in thinking about some of the technical challenges about summarization of those data. So we could certainly have more conversations offline. At this point, we don't plan to make our particular portal amenable to you submitting data, just because we don't see a really clear path on how to do that cleanly.
Thanks, Michael. We have about 14 minutes left in the session, just as a quick time check for everyone. And there are a couple of questions left, but please continue to send your questions in if you would like Michael to answer them. Michael, there's a comment/question about a person sharing their committee often is able to come up with a lot of community or system level recommendations, but they often wonder how to fund these recommendations or where the onus lies for project planning or implementation. Curious to hear your thoughts on that.
Yeah, so I mean, I think I have an opinion about this. I think the CDC team also has sort of guidance on what is the role of the MMRC in relation to recommendations. Like I would be surprised if any of the MMRCs are fully empowered to enact all of their recommendations, right? I think most MMRC recommendations are targeting different levels of health systems, and some members of the MMRC may be empowered to do parts of it, but some may be going to, perinatal quality collaboratives, some may be going to the legislature, some may be going to particular, continuing medical education. So I feel like the recommendations I'm not aware that the recommendations are actually being enacted by the committee in most instances. And I would say certainly that's the same with any recommendation that's about policy or community factors. That doesn't mean that there are not actors in the state who do have responsibility for that. So I think one of the powerful things about an MMRC is publicly summarizing the data for the distribution and the determinants of maternal mortality in your state, and making recommendations based on this multidisciplinary expert committee that are connected to that summary. So, if the recommendation is that the state needs to invest differently in transportation systems, sure, you can't individually make that happen. But I feel like there is a kind of political back and forth between this expert committee making a recommendation that's related to maternal mortality and a political body or a transportation authority that is ultimately the one that has responsibility for enacting it. There's a role for advocacy, for policy making. I think all of those things tend to be adjacent to the MMRC. So the MMRC is making these recommendations, but then always somebody else is involved in the translation of that. And I would think about that the same way for community factors.
Thanks, Michael. And just continuing, I think some of the questions that came in along the theme of where the address is coming from that's being geocoded. There's a question, what happens if they died in the hospital? Are you pulling all addresses from the death certificate? And what's happening for consistency? And I think hearing your thoughts on that last piece, happening for consistency, we heard you say earlier, start with that residence that's listed on the death certificate. But do you have any other thoughts about ensuring consistency, so we're all kind of using the same approach?
Yeah, I mean, I think well, first of all, so the residence on the death certificate, unless someone died in a long-term nursing facility, I think is always going to be your permanent residence. It's not, so if you died in the hospital, the hospital's address shouldn't be the address that's entered on the death certificate. The residential address is. So typically the address that you get on the death certificate is a permanent residence address. I think for consistency, the measure of the context that's most proximate to the death is going to be the residence at the time of death. I'm as a maternal and child health scholar, I'm also a life course scholar. And what I mean by that is I know that the thing that's immediately proximate to an event is not always everything that matters, that the things that you experienced before that event are important. So we may be missing information, but that's more difficult to parse. Which kinds of, is the birth always better, sometimes better? I think that the death provides the most consistent, clear definition of a context that is proximate to the final event. I think, moving forward, this is just me saying we're all early in this together. And so some of the best practices are still for us to collectively discern. Moving forward, we may decide for a broader range, or we may decide for a way of documenting so that we do have consistency, even if we deviate from that and include additional addresses. But I think probably the starting point should probably be the death certificate, residential address at the time of death.
There was a question that came in along the same kind of lines of recommendations to action, and I just wanted to encourage folks to check out some of the other concurrent sessions. They're being recorded and will be posted on the portal. There's a concurrent session titled Strategies and Approaches to Prioritization Action Planning based on the MMRC recommendations. So just wanted to put a plug in for that session, which concluded earlier this afternoon. I think that actually wraps up the questions that we have coming in, Michael. So we'll just ask if you have, oh, there's one that I think I missed here. Is a question about maybe taking a little bit of a step further and doing some analysis using these indicators. The question is, could you provide some insight on presentation of small numbers and incorporating social determinants of health indicators for small states? Even after 5-year aggregation, sometimes the cases are not amenable to meaningfully presented at a local level. So maybe some thoughts about how you might see analysts using these data points in their analyses.
Yeah, I think that's a frequent concern. Even in not small states, the numbers of pregnancy-related deaths are still small. I think that one thing that people think about when they think of local data is most of the census tracts have 0 or at most 1 death. It's rare that a census tract has more than 1 death, just because it's relatively rare. That probably only matters if you were making a map, if you were trying to visualize the spatial distribution of all of the deaths. I think when it comes to these indicators, I'm not sure that the localness is necessarily the problem. So if we go back to one of the previous questions and my conversation around it, so one approach would be to take all of the neighborhoods or all of the counties in your jurisdiction and to divide them into tertiles or quartiles along some dimension, like say the prevalence of housing instability. And then to describe the number of, the pregnancy-related mortality rate or the number of deaths that was in each tertile. Now you need to recognize that there may be more people depending on how you did your tertiles, if it was by places or by people. But I think you could therefore, you're not saying that they have to live in the exact same neighborhood. You're saying that if 2 people live in neighborhoods with high housing instability, then what I'm interested in is pooling them together and asking is, being in a place with high housing instability related to pregnancy-related mortality in my state. So, if you only have 10 or 5 deaths, then you do have small numbers. It is difficult to begin to do any statistical summarization. But if you pool over 5 years, I would worry less about the fact that there's only one death in a particular census tract, and think more about the distribution of the kinds of places, like places with more versus less number of OBs or certified nurse midwives, or places with more versus less access to transportation. How do the pregnancy-related mortality vary along those domains? So I do think there are ways forward, and I also I'm perfectly cognizant of the fact that, you know, at the state level, and particularly in small states, you know, luckily pregnancy-related deaths are relatively rare, even though as a rate compared to other places in the world, we're pretty high. But there are a small absolute number of deaths in many jurisdictions. But I don't feel like that in any way, that does not automatically shut down the ability to do an analysis in your state.
Thanks, Michael, and really appreciate you and your time today sharing these exciting updates and taking questions from kind of across the spectrum on recommendations to action, on the background behind it, the indicators, on actually analyzing some spatial analysis types of questions. So appreciate all of that. And for yeah, sharing the exciting update that states will soon have the ability to obtain their own dashboards. And you know, one thing that I wanted to mention, and I wondered if you could just spend the last couple of minutes talking about this, just the complementary resources, I think that, you know, are so important to states and to their interpretation and understanding and use of these dashboards that you shared in your presentation. So recommendations, reference tool, and the various trainings that will be complementing and supporting these dashboards in their use. So would welcome your closing thoughts, maybe focused a little bit more on those pieces that you covered in your presentation as well. And yeah, thank you so much.
Sure. Well, thanks, Toby, and thanks everybody for being here. Yeah, definitely there are a lot of resources, you know, just like I imagine that these dashboards are another layer of information. Those resources are a layer of resources. You know, perhaps you would feel overwhelmed by all the resources you have available to you, but it's good to know that they're there. So reviewtoaction.org has a lot of really important resources that can help your committees manage lots of the questions that I think substantially overlap with what we've talked about today. You know, some of these things are specifically about the dashboard, but a lot of things are, you know, how do committees make decisions? How do you make recommendations? What's a contributing factor that's meaningful, and what do you do with that? So we tried to be cognizant of the resources that already exist and try to produce information that's complementary to them. What we'll also certainly have in an initial form at the soft launch of the website, and will probably continue to develop over time, is more crosstalk or linkage, for example, between the EraseMMCVSproject.org and you know, things that, for example, the Black Mamas Matter report about how committees have inclusive conversations. So we could, for example, have some links that help you go from our portal to other places and identify what additional resources might be really important.
Great. Well, thanks again, Michael. And again, I particularly liked how in your presentation you tied our desire for ideal data to the real data we'll be able to see through these dashboards. So again, I know that a lot of states have been asking when will they be able to access them, and so it's exciting that that you were able to announce that states will be able to access these resources at the end of the month. And yeah, we look forward to the continued conversations and continued work post soft launch to continue to strengthen these resources and hopefully have you back again to talk to us in the not too distant future.
That sounds great. Thank you so much, Toby, and thanks again, everybody, for participating. I look forward to working with you.